Good morning. Welcome to our doc talk this morning. We want to invite you all to open up your chat messenger so that we can have questions that you're entering in, and we'll have a Q&A section at the very end. So make sure you open up your chat option. We're going to get started here in just a moment. So we're so happy you guys can all join us today. We're going to be having a really good talk, I think, about natural bone health supportives that we can all be thinking about. And I just want to remind everyone that we do these doc talk lectures every month, and they are free, and we welcome you to join and to tell your friends and neighbors. And we're going to be talking in June about sleep health. So I'm Dr. Molly Force, and this is Dr. Melinda Bauer here with us. And today our talk, of course, is on natural osteoporosis and osteopenia prevention. And of course, we are needing to say that this presentation is really just meant for educational purposes. It's very important that you check in with your primary care providers before you start any actual treatment plans. But we want to make this an engaging conversation today that you guys can really take information away with. So we're going to start by talking about the physiology of bone tissue, and Dr. Melinda Bauer and I are going to be going kind of back and forth on these slides discussing these things. So let's talk about what healthy bone is first, because understanding that helps us understand the building blocks of what we need for things to go right. So bone is a very living tissue, and it's really important to think about it that way because it's easy to imagine it as like a hard mineral substance that's very static, but in all actuality, it goes through this remodeling process and this turnover process, and it's engaged in this building process by two different cellular types. We have osteoblasts, which are constantly building bone, and osteoclasts, which are breaking the bone down. And this turnover cycle is about a 2 to 3 month turnover cycle. And that's really important because it means that we have the ability to redeposit bone tissue where we may have lost it, and also have bone thinning in areas that we prior had good healthy bone thickness. So I'll let you take this away, Dr. Bauer.
I'm having technical difficulties.
Okay.
I'm just trying to pull the screen up again. It disappeared.
Great. Oh, no problem. I'll just go ahead for this part. So the bone components, the big ones that we're often talking about are these different minerals. We've got calcium, which you've all heard of course, magnesium being really important, phosphorus, strontium, and boron. Now, all of these are essential minerals for us to lay down this healthy bone network. And we're going to talk about each of those and their importance as we go through here. It's also important to remember that because this is a very organic and living tissue, that we have different periods of our life that we have a lot of growth in the bone area. Of course, as we're children, we're laying down a lot of bone matrix, and up until we're about 25 years old, somewhere between 25 and 30, we're really laying down our peak bone mass. And so it's very important, of course, that we are encouraging young people to have healthy diets and intakes to make sure that they're digesting and getting the nutrients that they need to lay down those bone matrix. And then as we move forward with our aging, we start to have a natural decline in our bone mass, but it's really important to be thinking about it as a preventative thing, even, as a 30-year-old, 40-year-old, and as we're looking forward, especially as women, it's a critical component for us. And we're going to talk about why that is for women here coming up as far as our hormone involvement. Did you get the slides up, Dr. Melinda? Do you see them?
It says it's launching.
Oh, no.
Okay,
You let me know. So can everybody else see the slides okay? Okay, thanks. Thumbs up, perfect. So as far as the natural bone, we see this as a matrix, like a linked together network of these minerals. And as we have bone thinning, we have more and more spacing between the bone matrix. So this is just a nice visual for people to see what the actual microscopic bone is looking like as we start to undergo these processes of the thinning, and as we go between osteopenia, which just means a general thinning of the bone, all the way to osteoporosis, which is our diagnosis of more severe bone loss. And when we get into the osteoporotic component or stage, that's where we're looking at really having risk of the bone fracturing and degrading to the point that we have serious pathology or damage for people. And then the severe osteoarthritis and osteoporosis can also lead to the bone thinning to the point where we also have degradation and can undergo, of course, even easier fracturing. So there are different testing that's available, and we've got imaging that's most standard called Dexa, and most of you have heard of Dexa scans. And they're a type of a type of x-ray essentially that's done that is used to measure the bone thickness. And typically we're recommending this for anyone who's at a higher risk over the age of 50, especially for women. And then women over 65, generally we're looking at this scan being something that's a really helpful indication for us and helps us track the different areas of thinning. Often we're looking at hip, and we're looking at spine for these, but we can also look at different areas of bones, like wrist and even ankle, sometimes for Dexa scans. But typically we're looking at hip and spine for these. And so generally most insurance companies are covering these kind of preventative screening exams every 3 years. For women who are osteoporotic and have that diagnosis already, generally I like to personally see those every year because we want to be tracking and making sure that we're making progress and keeping that bone integrity. Dr. Melinda, is that
Yes,
on?
I can see now too. The other thing I wanted to mention, you mentioned that we have urine tests and blood tests, that we have some other ways of getting an idea of what our bone loss is like for patients, especially if we know they have osteopenia or osteoporosis. And these tests, similar to the Dexa, can also give us information on how our treatment is working for them. Because if you're waiting potentially up to 3 years to get a Dexa and we're doing treatment, we may not want to wait that long to be able to determine if the treatment that we're using is effective.
Absolutely. So the urine testing and the blood testing can be nice markers, although they're more immediate markers as far as what we're losing in regards to the minerals. And so the other component with bone testing is it may not be looking for specific mineral markers, but we may be looking at other markers that are on very inexpensive forms of lab tests, like a comprehensive metabolic panel, to look at how your organs are functioning, and that can give us understanding as physicians as far as areas that might be at risk. Additionally, we may be looking at hormonal markers as well, and that can be through blood or saliva, or technically urine as well for some people. Okay, so when we're talking about the diagnosis of osteoporosis and osteopenia, we're looking at these standardized numbers, and these are numbers that are calculated on the Dexa. And so we're really looking at for this zone of T-scores that are below, that are -1 to -2.5 being osteopenia, which remember is just that thinning, and it puts us at risk, but not as grave of risk as the osteoporosis, which is considered to be when the bone has thinned to the point that it's under the -2.5. So this is looking at the average person's bone thickness in comparison to your own when you're looking at these numbers. And so it's a calculated number that can be helpful in our tracking of these states. So as far as bones that are most at risk, many of you know that when we fall, we're at most risk of having a fracture. And typically the hips are one of the areas that we want to really think about making sure we're not having damage to, because as we become elderly, our hips are very hard to repair and can be detrimental to people to have injury there, and they may not recover. So the most concerning areas for us are our hips, also spine, and then wrist. And the reason for wrist is because it's outstretched whenever we go to fall. And so a lot of impact can go there. And so when we look at our risk of hip fractures, of course, it's going to increase as we age, because just like we looked at that chart earlier and saw the reduction of the bone density as we age. Of course, that makes sense to everyone.
And one thing that you may notice when you look at your DEXA scan is you may notice that one area is actually a normal bone, and another part of your body you may have osteopenia, and yet a separate area may have osteoporosis. So you can have different levels of calcium in different bones. So for the most part, we're looking at any area that has less bone mass than we would like, but just know that that's a common thing to see on the scan as well.
And we're going to talk about why that is as well here coming up. So when we're thinking about who's at risk, of course, we're really thinking about anybody who's elderly because of what we've talked about before. As we age, obviously, we're reducing our bone mass. And women, and that has to do with the hormonal component. And you're 4 times more likely, being a woman, to have a reduction in bone mass. And that has to do with how our estrogens work with our bone reabsorption, with those osteoclasts and those osteoblasts, those bone builders and bone breaking down cells. So when we have a reduction of our estrogen, which happens post-menopause, so usually around 50 years old for most women, we start to see that the bone structures start to thin and degenerate. And a component of that can also happen whenever we have any kind of estrogen blocking medication, or when women are naturally going through menopause and then have below normal physiologic levels for whatever reason of their estrogens. So a few different reasons for that. So it could be pharmaceutical, or it could be a natural progression. Also, if we're thin, we have generally less bone matrix to start out with, so that puts people at more risk. Anytime there's been an eating disorder that's affected the ability for the bone to be built in the first place, or an issue with our mineral deposition in the first place, that's going to put us at risk. People who are hypothyroid as well, so not hypo, but hyper, where their metabolism is very rapid and maybe they're not able to absorb as well. And with that autoimmunity, typically, that can also lead to thinner bones. Smoking is another one, and there are a few different reasons for that. One of the biggest ones, I believe, has to do with the oxygenation and our vascularization. So getting the minerals out to these peripheral structures so that our bones can use them and our cells can use them to lay down the bone matrix. And then alcoholism, because the way that alcohol is going to block our absorption and cause us malabsorption syndrome, potentially for people, and that has to do with the calcium being able to be absorbed. There are other reasons, of course, for having lower bone mass, and another one that's not on this list that comes to mind for me immediately is if we have any kind of issue with autoimmunity or malabsorption syndrome in general, specifically for the gut. So people with Crohn's or ulcerative colitis are going to be at greater risk as well.
And then, of course, you're going to have different medications that can also cause bone loss. So corticosteroids, if there's a long-term use, usually long-term, we're talking about many weeks to months. Those are going to have a potential to lead to bone loss, including prednisone and cortisone creams. A lot of breast cancer therapies, especially the ones that are targeting estrogen receptors, those have the potential to create bone loss. Diuretics, if you're increasing the secretion of calcium through your kidneys, then obviously your bones are going to have that calcium, so that's going to have a tendency to lead toward bone loss. Long-term use of blood thinners, as well as anti-seizure medications. If you have low thyroid and you're on too much thyroid medication, then that can also lead to bone loss, as well as some specific cholesterol medications like the Questrin.
And then we have these different signs and symptoms, but often the body communicates a lack of bone matrix in a silent way initially. We can start to see things like the loss of height because we start to have a stooped position from this as it progresses. And then of course, things like back pain can happen because we have a decrease in that bone matrix. And so we get this rubbing that can occur as the bones begin to get thinner. And then as it progresses into that osteoporotic range, we have, of course, the risk of fracture that can happen. But usually we're looking at about 30% of bone loss before we see any of these symptoms appear. So we really want to be thinking about making sure that we're taking care of that before that happens.
So conventional approach to either osteopenia or osteoporosis would include bisphosphonates. The mechanism that this particular drug uses is it stops that osteoclastic, that property of the bones breaking down so that they're not having that breakdown. There are many adverse effects to this particular class of drugs, including esophagitis, esophageal ulcers, headaches, abdominal pain, acid reflux, nausea, and there's a tendency to have a weakened bone matrix with this system. A lot of our patients will come to us because their doctors have suggested they go on bisphosphonates, and for various reasons they might not want to, or they may want to talk about other approaches. So we also talked about on this slide some other really critical supplementary nutrients, including calcium, which makes a lot of sense if that's what the bone is made of. Vitamin D3 has a really important piece of bone. And we also mentioned earlier some of the other minerals that are part of bone that we can make sure to support for a particular patient.
And then, so obviously you're all here to really get a good understanding of what we can do about this. We just wanted to make sure everyone had a good background of what healthy tissues should be and what healthy bone should be. So when we're thinking about the natural approach, we kind of divide it in between diet, so nutrients coming in, exercise, so what we can do to build the bone through mechanical input, and then hormonal balance. And when we get into the exercise component, that's going to really help us understand how we can target different areas as far as helping to rebuild the bone. So like Dr. Melinda was talking about before, you may have certain areas that are considered to be normal bone, healthy tissues, and others that have degenerated. So that segment, that exercise component really helps us hone in on those specific areas, whereas diet and hormonal balance is going to be more of a whole body approach for your bone. So as far as the weight-bearing movement, when we're thinking about exercise, it's really important that you understand that those bone building cells, the osteoblasts, need a mechanical stimulation. So when we have the correct posture, we are stacking our load. If you think about like stacking loads of stone on top of themselves, and we're resisting gravity through that stack just by holding ourselves up. And as we do that, the muscles pull on the bone. So the tendons, which attach to the bone, pull on these very small cells, and that tells the bone every time the bone and the tendons get pulled, we get the signal to the osteoblast to build and to reinforce at that junction of the tendon, which is that attachment of the muscle to the bone. So it's absolutely critical that we're sending different areas the mechanical information. So the old adage, use it or lose it, is absolutely apt in this kind of scenario with bone. So when we talk about really critical movements and exercises for bone health, one of the first things that comes up in a lot of the literature is walking. And one of the reasons for that is we are stacked in that vertical space, and we are resisting gravity as we walk through, as we go through the normal motions of the arm swing. So what we're getting there is we're getting the weight of our head communicating with all of the tendons that go attached to our spine, and then our hips are involved there too. So this helps with the bone density in our legs and hips and spine and all of these, what we would call central or core stacking bones. So the other components that can be really helpful for this are other exercises that are going to be bearing exercises that use your own natural weight as well. So things like Pilates and yoga can be really great for this. And yoga in particular is going to affect your ability to work on different bone areas. So you can be doing things like different stretches like downward dog, where you're on your hands and your feet and kind of a triangle-like pose. And you're really starting to work into your arms and your forearms and strengthening those wrists from that load. Also, we want to think about weight-bearing exercises, of course. So typically for women who are postmenopausal, I like to start out with very small amounts of weight. We may even just start out with their own body weight, like I was talking about with the exercising, with the Pilates and the yoga. And then we'll start to convert into adding half a pound to a pound, maybe even using things like soup cans from their own kitchen cupboard to begin to incorporate some of these extra weights. Things like ankle weights when you go on a walk can be a really good addition as well, or wrist weights as well, because that helps. As long as we have that proper stacking, then we are really engaging against gravity there, and that helps with that mechanical laying down of bone tissue, which is absolutely critical. Anything to add to that, Dr. Bauer?
Nope, that's perfect.
The other piece there that I will share is there can be mechanical stimulation through different objects like vibratory platforms. And so it doesn't have to be as simple as walking, although I love, plugging the natural walking. But you can also add things like a vibratory element, and there are lots of machines and things like that out there that can be really helpful, specifically to target different areas if you have at-risk areas, because whenever we're vibrating, our cerebellum of our brain is trying to keep us stabilized, and so it's going to send those muscles as signals to engage your tendons, and that's going to pull on those bone tissues, and that will say, hey, osteoblasts, it's time to build and to strengthen.
Some nutrient considerations that we'll talk about include either eliminating or avoiding phosphates as much as possible. The main reason that we want to do this is because phosphates can block that mineral absorption, which is definitely not what we want to do. And in general, phosphates are found in grains, legumes, unsoaked nuts. So this is one of the reasons that we encourage our patients to soak their nuts overnight, as well as some grains and legumes. And then soda pop also has phosphates in them. So these are things that we want to avoid as much as possible, so that that mineral absorption is actually happening in a natural way.
Foods that are going to be helpful for the building of our calcium component of our bone matrix are things like leafy greens. We also really like our quinoa and amaranth. Those are more like seeds than, I think of them more like seeds than our grains. They're a little bit lower in the phosphates. The almonds are also on there. They're high in sulfates. As long as you're soaking them, that can be really helpful. One of my favorite things is just put them in a ball jar with some water overnight in the refrigerator, and in the morning or later on the next day, drain them, and then just keep them in the ball jar and just grab them as a little snack, and you can just squeeze them and they'll pop right out of the skin, which is really handy. And then sardines and canned salmon are some of my very favorite ways to get calcium, for example, in my kiddos who have a low dairy intake. And one of the reasons for that is that they have the small bones in them. And when they go through that canning process, it softens those bones, makes them very edible. And so I find as long as I add something else a little bit crunchy to the mix, like parsley or something like that with the canned salmon, it makes it very enjoyable. And then soy products are also known to be really helpful for bone building. And the reason for that is that they contain phytoestrogens. And so that estrogen component we talked about before is actually very critical here for supporting our bone matrix. And then dairy is the other big one that's often touted as really critical, although some patients do not do well with dairy, and so it's not my number one go-to as far as calcium. In fact, if you have a dairy issue and you're using it to get healthier bones, then it can actually cause some inflammation. And we know that inflammation is a huge component for osteoporosis. And so mitigating that inflammation actually helps reduce the risk of having that bone breakdown occur at a more rapid pace.
So another great food source is grass-fed butter and pasture-raised butter, or any kind of dairy really. There's a whole list here of things that it includes. And the first one is the conjugated linoleic acid. This is something that's found in fairly high amounts in grass and pasture-raised dairy, as well as vitamins, minerals, amino acid. Activator X is a specific piece of this dairy as well that has been found to be really helpful in mineral absorption. And you're going to find higher levels of the linoleic acid in the Activator X in pasture-raised and grass-fed, more so than conventional dairy. So if you eat dairy and you're okay with that, make sure to keep this in mind as another way to support your bone health from what you're eating, your nutrition.
And then a question that comes up quite a bit in my practice for people who are having that dairy is that idea of, should I get pasteurized versus unpasteurized? And pasteurization, of course, is really important for not having us get sick whenever we have the milk, and for the ability for us to have more shelf-stable products. But at the same time, whenever we go through that heating process, we're killing off a whole host of probiotics, good bacteria, and then we also can make some of our enzymes in there that are very important to help us utilize these minerals that are in that dairy more unstable whenever we do that heating. So unfortunately, the pasteurized is not as good as the raw milk as far as nutritional value. There are some states where it's totally illegal to even access raw milk. In the state of Washington, we can get raw milk, which is really wonderful, but we do want to be careful about looking at how the dairy is processing the milk, making sure it's coming from a clean processing facility, and also making sure we're paying attention to expiration dates, and then of course how the milk presents. Like if it doesn't smell right, it's probably time to flush it down the drain, or use it for something else, ferment it into the next stage, like a yogurt or something like that.
So these are other food sources that you should consider when you're trying to focus on bone health. We know that magnesium is an important part of bone health, and there's all kinds of food that have high amounts of magnesium, including sea veggies and whole grains. And my favorite is the leafy dark greens. For some of my patients who, let's just say, maybe eat a salad every day full of dark veggies, then they're probably getting a fair amount of magnesium in that particular serving. And then boron is another really important mineral for bone health, and you can also get that in sea veggies. So including these foods in your normal daily nutrition components will help your bones as well.
And then, of course, there's supplemental calcium, magnesium, and this is a huge topic. The biggest question in my practice comes up as far as what type, because there are so many different types out there. There's a huge variability. There is there are calcium and magnesiums that are going to be wonderful and easy to absorb, and others that are really not going to be absorbing well. There was kind of a joke when I went through my radiology course in medical school, that we would look at these x-rays and see in colons who had taken their calcium supplements. If they were taking big hard tablets, they kind of get pooped out like rocks or like stones and not be absorbed. So when we're thinking about the form, we're thinking about two components. We're thinking about the form of the mineral itself. So there are subforms of calcium like citrate, malate, carbonate, oxalate. Those are kind of our common ones that we're talking about. And then there's also the form of the actual supplement as far as how it's being delivered, the delivery form being either liquid, powder, or encapsulated. Or tablet. So the hard tablets are ones that I'm usually telling people to avoid unless they have a specific easy release technology, because we don't want you having this calcium come in and then not being able to actually utilize the supplement that you're taking. That defeats the purpose of it. So generally I'm recommending for my patients powders or liquids that are very easily absorbed, or capsules that will just open up and be a powder that is easily absorbed by the intestines. And then as far as the type of calcium, there's a ton of research out there that just really solidifies that calcium citrate or calcium malate are some of our best absorbed forms of calcium. And when we're looking at those, our magnesiums are also going to have these subtypes. So for some people, they do better with different forms of magnesium. We're going to talk about that a little bit in a second here too, as far as glycinate versus citrate versus malate. But there are different forms, and some are well absorbed and some are not as well absorbed. So when you look at the studies as far as how many milligrams of these minerals you need, that's really important to take into consideration, because for example, a calcium carbonate is very poorly absorbed, and that's what most of our calcium magnesium products that you find over the counter are going to be made of, and they're hard tablets too. So the absorption for that is very poor in comparison to something like a calcium citrate or a calcium malate. And so you need a higher milligram of the calcium carbonate if you're going to be taking one of those kind of standard products than you would a calcium citrate or malate. So when we're looking at calcium magnesiums, often they'll come paired, although you can get them individually. It's very important in general for most people to take your calcium with a magnesium, because it will help you with that balance that you need for the bone matrix, but it also helps with some of our prevention against things like kidney stones whenever we have that magnesium added in there. Specifically, magnesium citrate has been shown to reduce calcium oxalate stones, which is the most common form of kidney stones we get. So the risk of taking calcium, especially a poor absorbing form of calcium, is that we have excess calcium then circulating potentially in our blood vessels and not depositing in our bones. And so that, for me, makes me concerned for people as far as more plaquing in their blood vessels, plaquing in their brain, and then the biggest, quickest problem that most of these people will have when they're taking large amounts of calcium unchecked is the kidney stones, because the kidneys are going to be so responsible for filtering out that excess calcium that's not being absorbed in by those bones. So there's also a timing component too when we want to usually take our calcium magnesium. Often I'm recommending in the evening because it can help with sleep. There's tons of research on that, supporting that with good evidence. And then there's a question for, should I take my calcium with or without food, my CalMag? And generally it really depends on the kidney health, but for a lot of people, taking it at dinner or with a larger meal in the evening, not that you want a huge meal in the evening, but with a meal in the evening, it can help reduce that calcium oxalate production, which will help reduce kidney stones. When we're talking about the percentage of calcium to magnesium, different products have all kinds of different percentages, but the general ratio that we're looking at is a 2-to-1, 2 parts calcium to 1 part magnesium. And so for the highly absorbed forms of calcium and magnesium, like a citrate or a malate form, we're usually looking at between 600 milligrams and 1200 milligrams of calcium. Versus if we're looking at a calcium carbonate, we're usually looking at between 1,500 and 2,000 milligrams, according to the research, a day of the calcium. Often we'll also want to divide our doses up if we're taking them in a pill form, because it's hard to pack that much calcium into a pill form. So people will end up with 3 or 6 even pills. And so dividing that dosing can help with the absorption as well, if that is the form that they decide to use rather than a powder or a liquid. Anything else, any other wisdom you want to add to that, Dr. Melinda?
Yeah, I wanted to add that the reason these doses for calcium and magnesium have such a wide variance is because, you know, it really depends on you as a particular person. If you're a woman in your 20s versus a man in their 40s versus a woman in your 50s or 60s, all of those different scenarios are going to have very different calcium needs and bone needs based off of what we talked about before. The other thing I wanted to mention is that especially if you've been diagnosed with osteopenia or osteoporosis, there's very specific levels that we're looking for in a day. And the other thing that we take into account is how much calcium you're getting from your food. So in an ideal world, we would say, okay, if you had osteopenia and this is the amount we decide you need per day based off of your age and your lifestyle, and we know that on average you're eating this much calcium in your food, then this is how much calcium and magnesium we need to supplement. So this conversation is a little bit more difficult than we can present to you, because it takes into part all those specific pieces of you as an individual.
Yeah, absolutely. So we do want to think about this individualized, absolutely. So for example, as far as one of my favorite calcium magnesiums, just want to show you guys some, not saying that you should be taking these specific ones, but just want to walk you through some of the reasoning that I'll use as a clinician. So one of my very favorites is this liquid calcium magnesium that's made by Pharmax. It tastes like blueberries, which is delicious. My kids, for example, absolutely love it. But what I like about it, liquid form, it's very palatable, not acidic, and it has multiple smaller doses of accessory minerals in there. So it has boron, for example, in there, and it has some vitamin D3, which we're going to talk about here in a second, and K2. So, and a really important other supporting nutrients for building that that bone matrix. The magnesium component, when we're thinking about the calcium magnesium, can be absolutely critical for active patients. So whenever we go through a muscle contraction, our muscles are utilizing calcium to do that contraction with the actin and myosin. And whenever we go through our muscle relaxation, we're using magnesium for that. So for people who are increasing their exercise load, or are very highly active people, or have a metabolic need that's requiring more calcium or magnesium, for example, pregnant women, it can be absolutely critical for reducing things like restless leg at night and leg cramps and just muscle cramps in general, muscle tenderness. As far as their rebound, what I would call rebound to their movement or their exercise. So that's always a consideration as well. So it's a good segue into how fabulous magnesium is.
So there's all kinds of benefits of magnesium besides the ones that we've already talked about. Obviously, it's going to be helpful for your bones. One of the reasons that we encourage our patients to take CalMag at night before bed is because the magnesium can be really helpful to help you, your body and your mind relax for sleep. It also supports the muscle function, like what Dr. Molly was talking about with the relaxation of the muscle. And it's great for the cardiovascular system and the heart, as well as for the brain. And just random, I'm going to mention because it popped into my head that it's actually great for headaches too. People who get headaches frequently can be helped with some magnesium. One of the things that we frequently talk about with our patients is magnesium levels based off of bowel tolerance. So we're all different in the way we're sensitive to magnesium. And frequently we will start you on a dose, maybe something between 250 or 500 milligrams a day, and we'll say to bowel tolerance. So if you're really sensitive and you take a small amount of magnesium and it gives you diarrhea, then obviously we need to back off. And then we have other patients who are much less sensitive, or maybe they're even constipated, and we might actually increase that magnesium to get closer to a level where our patients would have regular bowel movement. So it's a nice side effect, helping with bowel regularity, as long as it's not creating too much looseness with your stools. We talked a little bit before about some of the different types of magnesium. We have actually many different types of magnesium, but some of the ones that are most effective is the magnesium citrate, magnesium citramate, and the magnesium glycinate. A couple of reasons we may pick the glycinate over the others. One is that it's easier on the intestinal system if you are really sensitive. The glycinate is also really calming, more so than the others. So it's, especially if you're having a hard time falling asleep because you find your mind is spinning, or you need more calming in your body before sleep, we might actually pick that glycinate to enjoy that calming piece of glycine in that magnesium form.
Right. And one of the reasons that I will pick citrate certain times has to do with if somebody has had history, for example, of that like kidney stones, because we know that citrate is such an awesome binder for calcium oxalate. And so it will help remove any of those excess stone or gravel creation from the kidneys. But yes, we love that magnesium glycinate. It's very easy on the system typically. So vitamin D sources, vitamin D, as you guys know, is absolutely critical as well for bone health. We have, the availability of it very infrequently here, unfortunately, although today is nice. So sunshine is going to be one of our very best ways to get our vitamin D. But theoretically, because of where we are in Washington, we're going to also, most of us need some supplementary vitamin D. We can also naturally get vitamin D through liver sources. So cod liver oil is one of the most common kind of remedies that's considered a natural supportive for this. It has vitamin A and vitamin D in it, which can be helpful for those bone tissues. And then of course there's supplementary vitamin D, which many of us take or are on. And those come in, different gel capsules, and then my favorite is liquids because they're cheaper. You don't have to pay for the encapsulation process. But it's really important to think about our blood work here. And one of the big things I'm advocating for my patients with bone loss or reduced bone mass is that they're getting a yearly check-in of their vitamin D levels. And the reason for that is vitamin D is so critical that we keep that nice and level. And so we want to make sure that our blood work is reflecting that. So once a year, I like a check-in to see what levels we have, and then we can adjust if we need to during the summer. Usually spring, right about now, is my favorite time to look at that. And then if for some reason we miss that check-in time for our vitamin D levels, I'll ask for people to get it in the fall, because we do not want to go through a season of the winter with low vitamin D levels and having that help to quicken our bone loss. So it's a very important one to check in with, and pretty inexpensive, and can be usually added on to most general blood screening that's done. As far as the sun exposure, I should also say, of course, we want to protect ourselves from UV rays, but generally 15 minutes of sun exposure before we put on our lovely sun hat and longer sleeves to kind of protect our skin can generally be enough to at least jumpstart. Now, different skin types are going to absorb vitamin D differently, and so that's something else to take into consideration as far as how much the melanin that you have, that will affect it as well. So really the best way to know is having a baseline level with your blood work, and then your physician can help you adjust those numbers. Melinda, is there anything else you want to add? Maybe we should talk about high doses of vitamin D, because that's kind of a controversial thing in the natural medicine world.
Yeah, well, kind of based off of that blood work, we do have some patients that are taking relatively high levels of vitamin D for various reasons. Some of us have genetic pieces that make it so where it's hard for us to absorb vitamin D. So some patients might be on a higher level to get to that ideal blood marker that we're looking at, so that they can, so we know that they're getting the appropriate amounts of vitamin D. And then maybe you guys remember when we were talking more about immune support during this COVID crisis, that sometimes with immune support in general, we will talk about a very brief 1 or 2 day heavy dose of vitamin D just to support our immune system. We know that vitamin D is critical in our immune response. So especially if a patient is low or tends to be low, we may ask for a little bit of a higher dose than a normal daily dose during some sort of immune support process. So those are some of the reasons that we may ask patients to actually take higher doses of vitamin D. And I would say a normal dose of vitamin D is usually somewhere between 2,000 and 5,000 IUs a day for an adult. It's much less for children under 9. You know, we sometimes have patients on 10 or 20,000 IUs a day to get to that level when we run their blood test, that it's what we would consider normal.
And the reason, just to reiterate, that we want to get the blood test is, of course, we don't want it to be too low, because that's dangerous for our bones and our immune system. But if it's too high, we risk liver toxicity, and that can happen pretty rapidly for patients. So I've seen it a few times in my practice that people have misdosed themselves on vitamin D, or have gone unchecked for many years, and all of a sudden they come in and they're not feeling well, and they just have sky high levels of vitamin D, and that can be incredibly dangerous. So one of the reasons that we don't just say go out there and just take vitamin D willy-nilly is that it can be very damaging. So we have a therapeutic range that we're really kind of trying to hit, and we don't know what is right for an individual until the testing is done.
So another vitamin that's really important for bone health and goes hand in hand with vitamin D is vitamin K. And you can see this particular example that we have on the screen is a vitamin D with K2 in it. Vitamin K sources, whenever you're eating fermented probiotic foods, it will actually produce that vitamin K for you. Obviously, we encourage patients to get that from food sources when possible, but if a patient's not eating fermented products or probiotics, then we may actually supplement with K2. Some other foods that are high in vitamin K include blackstrap molasses, all the dark leafy green veggies, green tea, oats, and alfalfa sprouts. And then you can see in the supplementary, K1 is best to get to obtain from plants. K2 is the one that we have mentioned here, and then K3, for the most part, is a synthetic type of K that's not it's not as good of a choice as K1 or K2.
And K2 is really interesting because it's the best for bone health. So when we say best here, we just mean that the research is really behind it for our bone health. And with K2, it's really interesting because it's one of the few vitamins that I know of that does not have a therapeutic upper limit on it, which I think is really wild because it's a fat-soluble vitamin, and usually those have very narrow therapeutic windows like what we see for vitamin D. Now, K1, on the other hand, does have a narrow therapeutic window, and we worry about things like blood thinning when we take excessive amounts of K1, especially if we're on certain blood thinning agents or pharmaceuticals like Coumadin, warfarin, those kind of things. So K2, having a supplement that just has that form, the K2 form in it, will enhance that vitamin D absorption and is generally considered incredibly helpful for bone matrix building, and is what I consider one of the 4 essentials for the stability of the chair, if you will. So we've got calcium, magnesium, and vitamin D and vitamin K as those critical components for bone health. So probiotics are on here because without our probiotics doing their healthy routine, then we're not going to be producing our own endogenous vitamin K. So vitamin K is a really interesting thing in the form that we need for our bone health. It's not usually something that we're ingesting unless we're taking it in a supplementary form. We're relying on our bacterial friends in our gut to produce that. So for people who have any kind of GI disturbances, it really does put them at another higher risk, not just because they may have a hard time absorbing those minerals, but also because they might not be making their vitamin D. So as far as sources of probiotics go, of course, you guys know that the ferments are going to be a really important option for us here. And things like our sauerkraut, kimchi, kombucha, and miso are all really wonderful. And then we have our dairy things like our kefir and our yogurts.
Then we have food sources of prebiotics, which include a lot of different vegetables like asparagus, cabbage, Jerusalem artichokes, the greens of the dandelion, leeks, mushrooms, onions, and then we have quite a few other grains like barley and oats, rye, and then some other things that are somewhat random like bananas and maple syrup. So these are some sources of good food prebiotics so that your body can have that good probiotic balance.
And then we have the importance, of course, of balancing our essential fatty acids. And this helps with our inflammation. And we had talked about inflammation being a process, an active process of osteoporosis. So we really want to be supporting against inflammation. And so by supporting different seeds, we can help the inflammatory processes go away from those, what we call prostaglandins, that are promoting inflammation. And one of the most important components here oftentimes is our marine lipids. So our fats that are coming from fish oils, for example, and from our fish that we eat. And so those are our EPAs, which you see here, and they can help us convert over to the prostaglandins that are anti-inflammatory, these PGE3s and PGI3s.
So we talked a little bit about phytoestrogens earlier and some of the importance of estrogen in relation to bone health, especially for women who are perimenopausal or menopausal. When we define phytoestrogen, it's basically a plant that produces plant estrogens in the body. So it's a very interesting piece for women who might have low estrogen levels as they get older, to have this plant estrogen be able to come in, and basically it binds to the receptors, these estrogen receptors, and then the body says, oh, we actually do have estrogen. We didn't think we did, but we actually do. But all of those sources are coming from plants. So you can see there's quite a large list of plant-based foods that have these phytoestrogens, including lignans and isoflavonoids. Genistein is a particular type as well. Some of the common, I think there's maybe another slide that gives examples, but the most common, the next slide talks about examples, but the most common one that you've probably heard about and maybe even seen is soy. But you can see there's quite a list of different phytoestrogen sources in our food, so that even if you don't have naturally occurring estrogen, you can use these plants as a source of estrogen. I wanted to just mention that there's actually quite a lot of studies that show that these phytoestrogens can be helpful with different types of menopausal symptoms that some of our patients may be having, like hot flashes, as well as increasing the tissue in the vaginal region. You know, when our vaginal region has low estrogen, it tends to become thin and dry, and sometimes it cracks. So if your body says, oh, we actually have estrogen coming from plant sources, it will help that as well. We know that we already talked a little bit about estrogen inhibiting osteoporosis, so that's super important. And like I mentioned, for the most part, we might recommend phytoestrogen foods to help with our patients who we think or we know have low levels of estrogen, like women in perimenopause or menopause.
So one of the calcium, magnesium, vitamin D, and K supplements that I am often recommending to people, especially women, does have some phytoestrogen component to it that's sourced from something called genistein. And that is an antioxidant as well as a non-soy derived phytoestrogen that has been shown with different research studies that it actually helps re-regulate that osteoblastic building activity. And so there are studies which show that for women who are osteoporotic, that it can help actually reverse that and support that bone matrix in the rebuilding process, which can be very helpful. And this is something that, you know, we're really taking into consideration whenever we're recommending these as physicians, thinking about what is the patient's risk level. Phytoestrogens are really one of those things that have a lot of good to them, but also can have some risks. So we have to think about as far as estrogen dominance in the body and risk levels as far as family history and things like that for estrogen dominant cancer concerns. So as far as other information, we want to give you guys some time to answer any questions that might have come up during the talk. So feel free to type that into the chat if you want to now. And we do want to invite you to come and join us next month on June 9th. We'll be doing a talk on sleep and insomnia. And so hopefully any questions you guys might have now, feel free to put in, and we'll just give it a second and see what comes up. And we thank you all for joining, of course, today. Are you seeing any questions, Dr. Bauer? I'm not seeing any either. So we'll go, and unless there's one coming in, we're gonna probably sign out here. Hopefully this information is you know, stuff that you guys can start thinking about and incorporating, and don't forget the importance of that gravitational stack. Oh, here's a good one. Here's a question. So this question is, what is the best form or best sources of bone health with a diet for a gluten-free vegan? So that does become challenging, because whenever we're vegan, we're not going to have those marine lipids, which we know are anti-inflammatory and important for reducing the inflammatory component of osteoporosis or osteopenia. And then also, of course, we're not necessarily going to have the dairy component if we're vegan as well. So one of the most important things there is thinking about those leafy greens and thinking about ways to take foods that might be high in phytates and reducing the phytate load so that you're absorbing in your minerals a little bit better from that. And specifically, as far as some of the best sources, the literature is very on the side of some of those phytoestrogen foods like soy for people that are choosing to have vegan diets. And then also, you probably saw on the slide, I'll go back to it, that talks about management of the inflammation. You can see on this other side, the side here that's showing these prostaglandins on the other side from the EPAs. On the right, you can also see that the sunflower and sesame seeds help with that linoleic acid and the production of the GLA. We also have evening primrose oil, which is our GLA form. So those are really great anti-inflammatories that can be helpful for bone health. And then you can see there's a lot of cofactors that are listed here on this slide, different B vitamins, zinc, we've got magnesium again, and then vitamin C being really helpful for the conversion of those fatty acids. So those are going to be very important as well. The other calcium source that I kind of mentioned earlier, I'll just go back to it, was quinoa, and it's very close relative amaranth as well. Those are great options for being higher calcium sources, and they're also going to contain some magnesium in them as well, and some other microminerals, which are really wonderful. So those are good, you know, base things to include and incorporate in for the vegan diet. And then we also want to make sure we have those ferments as well for the bone health for a vegan. So we're thinking about like the sauerkraut and the kimchi and things like miso for that as well to help out with that vitamin K production. So anything to add to that one?
Yeah, I would like to summarize. I completely agree with everything Dr. Molly said, that I have quite a few patients who are vegan or vegetarian and who worry about their calcium intake. And I do think that we have quite a lot of vegetables to support, which most of our patients who choose to eat that way are eating lots of vegetables. So, you know, we go back to those main things. We're making sure they're getting enough calcium, enough of the vitamin D, enough of the magnesium, and enough of the fatty acids. And one of the, there's actually a really good source of algae omega 3s that we sometimes will encourage our patients to use if they don't want to use some of the other fish oils or some of the other oils that that some of our other patients who are not vegan might choose. But for the most part, as long as a patient is being aware of the food that they're eating, I do think it's very possible to get all of those main sources that we need to support bone health from diet.
The other plug there would be for sea veggies, because those are going to be so high in micronutrients. They have all that boron in there, and they're just phenomenal as far as being a really good mineral source. So adding some spirulina, adding some of, you know, kelp, hijiki, that kind of stuff to your food, not just like the standard nori, although nori is great too, but add those to your meals, and that can be really helpful to kind of round that out. But, you know, if, you know, most of us need to be checking in on our vitamin D status, for example, and it is important, you know, to get those general screenings done. So if, for example, you're working really hard on your diet and you're noticing that you're continuing to have decline every time you get your Dexas, it may be time to consider supplementation, because sometimes we get to the point where we need that for whatever reason with our absorption, or there's just a certain micromineral that's really challenging to get on the daily on the daily circuit for us. So the next question is, could you speak briefly about the infusions? So we're assuming you're talking about the bisphosphate infusions specifically. So let me see if we have a slide to start with that. Do you want to give your 2 cents on it, Dr. Melinda?
Well, you know, this is always a tricky conversation because a lot of our patients come to us, they've been diagnosed with osteopenia or osteoporosis, and their primary care doctor or their MD is suggesting that they get these bisphosphonate infusions. And, you know, we try to spell out some of the adverse effects just so that it's really clear what those effects are if you do choose that option. And, you know, ultimately it's a decision that our patients have to make. You know, we try to give as much information about like what we've talked about in this presentation of all the things that you need to support healthy bone, so that we make sure that you have all the pieces so your bones can be as healthy as possible. And then ultimately it's a decision that you have to make as a patient if you're going to choose to use the bisphosphonates or not.
And there are definitely patients that I have recommended using infusions for. They've gotten to that point where it is a life-saving strategy for them. So we're not trying to vilify by any means those medications. Generally, the bisphosphonates, which are often people know them as the oral ones, like Fosamax, is the most common one that people talk about. They definitely have some concerns for us as naturopathic physicians. You know, red flags go up because of some of the studies that have come out about jaw, bone brittling, and other areas of the body that are actually very brittle and so still at risk of break, even though the Dexa scan for those individuals who've been on those medications still look like they have strong bones there. When we actually look at the matrix that's been laid down from those bisphosphates, they're still very brittle and so at risk of having the actual break, which is kind of concerning. But I will say, when we're thinking about the infusions, which are typically done once a year by a rheumatologist, those generally are pretty well tolerated, I have to say, by my patients, and are generally, you know, the most important thing once a person has gone to that is that they stick with them, because there is some research that if somebody starts an infusion and then stops, that they have pretty rapid bone decline. But if they do end up starting at what Dr. Melinda was saying about making sure that the building blocks are there, because that medication is going to come in and say, okay, let's do it. Let's lay down this bone matrix. But if we don't have the nutrients coming in to do that, then I think that puts the patient at higher risk, is my theory, that it puts them at higher risk of having that brittle bone matrix being laid down. So making sure that any underlying factors that are influencing absorption in particular is just going to be absolutely key. So making sure you have the right forms of the nutrients coming in, whether it be through diet or supplementation, and then making sure that there's no what we would call obstacle to cure in regards to the absorption factor. So I don't see any other questions, but if anybody has anything else to add, this would be the time to do so. We welcome any other questions or. Thank you guys. We really appreciate you spending the time. And if you want, there will be a recording of this that you can go back to. It should be sent out later this afternoon. And we really appreciate seeing everybody's faces and having you all join. So have a good rest of your day. Thank you. And we'll see you next month, hopefully.